Well, good morning, everyone. When I put this talk together, it's quite a difficult sort of thing to do. I spent a lot of time thinking about it, and I want to recognise Amanda and Lynn, who are two of our nursing staff. Lynn's our CNC for Quality and Safety, and Amanda's our acting director of nursing, who helped me sort of put this talk together and think about it. I'm not going to talk to you about indicators or quality data collection or what to do if your unit's an outlier, because I think there's going to be other talks on that later on in the session which hopefully will address that. And what I am going to try and do is put some boundaries around what quality improvement is, try to give you some thoughts on some of the work of Peter Provenost on fostering a culture of safety in our ICUs and hospitals. And to context that, I'm going to look at some past quality improvement initiatives. And I'm going to use the new version 2 of the national standards, which Daryl's alluded to, which are not the version we're currently operating in, but the version that we'll be operating in from next year, to see how that can inform the agenda for safety and quality that we individually, as a hospital or as a intensive care unit, may want to set. And basically, I'm going to give you some examples of what we've been doing in our ICU, just to sort of let you know what we're doing. It's not rocket science, but I thought it was a good start, and I think they're a good platform to work from. So quality and safety really has been one of the main agenda items driving practice in our units, hospitals. I think it's ubiquitous now, and I think the ICU, although it's a unique microenvironment with its own challenges, it's really difficult to separate it from the hospital environment, and I think the two need to be regarded in a complementary fashion. There's an inevitable bureaucracy around safety and quality, but I think we have to, despite this, embrace it as a meaningful way of changing our practice and improving the healthcare system we work in, and it shouldn't be regarded, just as some people still do, as a tick and flick. Just to get through accreditation. It's about improving systems of care, I think, essentially, and to make hospitals safer for not only the patients but also the staff that work in them, and that includes people, health practitioners that work in ICU in a particularly stressful environment. Incidents that may be the result of a system failure, I think the individual health practitioner, we all need to remain current and ensure our own competency to perform our roles, and remain educated and trained and accountable for what we do. This definition of safety and quality, of a quality improvement, was from Battle and Davidoff, a fairly old paper from 2007, but I think it illustrates well the sort of triad there of and suggesting that there's a combined and unceasing effort of everyone, including everyone that works in the healthcare system, to improve, to produce better patient and population outcomes, therefore better health, better professional development for healthcare workers, therefore learning, and better system performance, in other words, better care. And improvement in all those benefits everyone and can inform what we do, can inform an ongoing agenda. Others have taken a more pragmatic approach to it, and this is from the Department of Emergency Medicine at the University of Ottawa. They have a very good website, and they have a more ABCDEF approach to QI, looking at AIM, get some background data, develop a change idea, discover an effect on outcome, and edit and evolve your program. Their key messages: start small but get started, and use it to develop your strategies, your agendas, and start with small projects, but use the right tools. I want to just go back now to some initiatives that have been used, that we're probably all familiar with here in the past, that continue to inform our agenda and continue to contribute towards what we do today. If you search Google, there's many thousands of results out there under safety and quality, and I think even more under safety and quality in ICU. They all have similar aims and structures. I'm just going to mention two or three. Just wanted to go back to this first report from the Institute of Medicine, and going back to the late 1990s, where this report was one of the first to highlight the magnitude of errors in the North American healthcare system. And the main points that came out of this report, and it really was influential in changing the way that, people started looking at the healthcare system. At that stage, healthcare was a decade behind other high-risk industries, for example, aviation and other industries which have high risk involved. Healthcare was way behind. The errors that were being produced were costly, not only in terms of a loss of economically, but also loss of confidence by patients and diminished satisfaction by both patients and healthcare professionals. And importantly, even way back then, the process of developing and adopting standards was seen as being important to inform expectations among safety providers and consumers. And I think this is well where our current standards fit into this. In amongst all this, the 100,000 Lives campaign from the Institute of Healthcare Improvement was developed. And I mention this because it's still very significant and still very influential. They were one of the first to develop bundled care and developed 6 strategies to improve outcome, including the deployment of rapid response teams. This was back in 2004. Initial projects were concentrated on ED and ICU, but later looked at transforming systems of care in hospitals. The study was criticised, this particular study was criticised because of the lack of baseline data, but it did generate excellent endorsement by bodies such as the American Medical Association and the CDC. I'll mention Daryl's also alluded to the Clinical Excellence Commission, and they have great work in New South Wales, and one of the big success stories from the ICU point of view, I think, is the CLAB ICU project, which came out of this and really showed that bundled care strategies do work very well. The New South Wales CLAB project, which I think we'll hear about later on in the conference, showed a significant drop, 60% drop in CLAB rate from 3 to 1.2, which was a great result, and I think it's even lower than that now. It's about 0.4, 0.5. It led on to education, raising clinician awareness, and providing audit tools, and also the registry we have now, the NZICS Core Registry, which holds the CLABSI database, and the NZICS CLABSI project, which was also very successful. I would note that we were doing pretty well from the point of view of this infection in this part of the world. The rate for in Pronovos study, which was nearly 8 baseline, ours was only 3 baseline, so I think a reflection of the care that we've always provided in this part of the world, which has been very, very good in terms of even in terms of this type of infection. We were doing very well even before this project started. I just want to go back to creating a culture of safety and the work of Peter Provenost. And I thought this was interesting because he's taken the original work of Donna Bedian, which was published in the 60s, and which evaluated the quality of health medical care and looked at structure, process and outcome. And he's adapted that to hinge in context or culture. So the culture of the environment you're working in is extremely important to the outcome effect you're going to get on patient safety. So structure, have we reduced the likelihood of harm? So is the harm level lower? Do we do what we're supposed to do? Process. How often do we harm is the outcome. An outcome is the most difficult, it's the most significant, for patients and clinicians, but the most difficult to measure. Process measures are collected while the patient's in hospital, such as indicators, and they're often very straightforward to measure, but they don't inform outcome that often. And structure, how is care organised? How are we delivering, how are we organising our care? And he asked the question, have we created a safety culture in our hospitals and ICUs? This can be looked at in a kind of this diagrammatic fashion where patient safety is at the end point. But organisational culture, patient safety culture, which is this shared sense of norms, beliefs, attitude, values, or if you want to look at it, if you ask someone, it's just the way we do things in this ICU, we've done it for years like this and we get good outcomes without any specific data, but that is kind of a culture, safety culture. Hinges into organisational culture, for example, the organisation that you're working with will have a set of norms, values, stories, behavioural characteristics of the employees that are working there. For example, Metro North, which is the healthcare organisation I work for which Royal Brisbane is pinned to, is implementing the ethos program. I understand many hospitals have got that around the country. The effect is varying, and they're heavily applying or promoting values in action type programs, noting that there is an established link between positive organisational culture and patient safety. You can measure safety culture in your organisation, and you can change it if you really want to. We should be moving from a culture of denial and reactivity through to a culture of risk management, integral and part of thinking of professionals and managers. I've used, for example, burnout as an example of this. In a denial culture, we don't have burnout, it doesn't exist. It's a fallacy, a sign of someone being weak. In a bureaucratic culture, the person might be having sick leave because of burnout. Well, just make sure that the sick leave is documented. Don't worry about anything else. In a generative culture or a proactive culture, you might want to look at individual and systemic factors, work-life balance, career progression, coaching, mentoring, support, flexible rostering, etc., etc. So we need to move from really a culture of, well, this is the way we've done it here, we don't think any other system's any better, to more, which is, I think, a culture of reactivity and bureaucracy, more towards a proactive and generative culture. So I think fostering a culture of safety within our ICs and hospitals is key to achieving longevity in our QI agendas. And I think we have to try and do that to improve outcomes and to make sure the agendas we do set are carried on. So I want to, with that, just go in the last part of the talk to the new standards. And Daryl's already alluded to the 10 standards which we're operating on at the moment. The Australian Commission on Safety and Quality Healthcare have produced new standards, which are called version 2. All hospitals will be accredited against them from next year onwards. I think they are key to informing what we do in our healthcare systems. Just want to quickly go over, sorry about the small print on the left side, but what are the changes really from the 10 standards. We had 10 standards with 256 actions, we've now got 8 with 148 actions. Clinical governance continues to recognise the importance of leadership and culture in establishing systems. I think the ones that I've listed, the ones that I've got a sign by, it basically means that I think the ones that are going to impact on ICU. I think our ICU will be impacted on partnering with consumers, involving patients in decision making around their own care. I think is going to become extremely important and something we're going to have to engage in more. The healthcare infections remains very strong and is really linked around antimicrobial stewardship and preventing healthcare associated infections. There's a stronger focus on medicine-related complications, polypharmacy. Are we prescribing the right drugs for people? Are they getting followed up? Are they getting discharged from ICU on the wrong drugs, or on, is omeprazole being continued for the next 3 years, which happens? And the big one is comprehensive care, which is rolled in falls and pressure area prophylaxis, pressure ulcer prophylaxis. This is also going to be a big area for us with mental health and cognitive decline coming into this, plus also covering end-of-life care, which is also crucial for intensive care. It will also incorporate Aboriginal and Torres Strait Islanders' health. Structured clinical handover, crucial for us. We'll hear about that later on in the conference. It's a very high time for communication, high risk time for communication error, and it's extremely important. And lastly, recognising and responding to acute deterioration, which is now standard, well, when the new standards will be standard 8. And the big one there, I think, is that there's going to be an enhanced focus on delirium. So not only are we going to be responding to physiological deterioration with the current rapid response systems, we're going to be having to incorporate and manage delirium on the wards, delirium in our patients, and it's a huge area, one of which is probably, as Daryl's alluded to, underestimated, and it's going to become an increasing problem with the population that we're getting into hospitals, the aged population, patients with multiple drug and alcohol problems and multiple medications. It's going to become an increasing problem for us. Can we use these standards to set our agenda? Well, I think we can. What we've done at the Royal Brisbane, and I'm not suggesting that that you do this, but I'm suggesting that's maybe a good way to start, and many of you will be already doing this. I'm not trying to preach to the converted. I'm just trying to give you some idea about what we're doing. We've assigned to every standard a clinician who may have an area of expertise in that part, and they'll be working with allied health, with pharmacy, with other areas to try and evolve the standards and develop them as we go on. They'll all report to the QI meeting. One thing we found very, very, very important in our hospital is to develop a widely inclusive quality improvement meeting, and that's our agenda. We have an action register that comes out of that every month, whereby any items that are actually rolled over from the meeting get reported and followed up, so we can close the loop on basically what we're doing. And we found that very, very important for bringing the unit together, bringing nurses and other staff, allied health, physios, speechies together just to give an overview about what is actually going on in our unit in terms of quality. Lynn, our CNC, comes to that meeting and is always updating us on quality and safety standards from the national standards point of view, and that's always very useful. So what are we doing? Partnering consumers. We've taken initiatives. This is an ICU STEPS program developed in the UK. One of our consultants, Marianne Corraine, is partnering this and trying to drive it through, whereby we're trying to improve the interface for relatives and developing strategies to try and improve the entrance, improve the front door of the ICU to families, adapting queue management systems, looking at ways we can support families and relatives, and promoting the recognition of physical and psychological consequences of critical illness. It's a big area, and we're adapting some of their material with consent. Healthcare infections, we're not doing that well with hand hygiene. We're constantly working on it. We have monthly audits, dedicated nursing groups, gels and foams widely available. We have an antibiotic stewardship program, which everyone should really have. And we're fortunate we have very good ID physicians and twice weekly rounds with our pharmacists. We had the ability in our ICU to use our MetaVision clinical information system to record electronically data, and with that we've adapted a CLABSI database, which is filled in by every consultant every week as part of their databases to assign whether there's a CLABSI or not, which is a way of us keeping tab on our infections without actually having to go back retrospectively and look at them, which is what we were doing in the old days. So that's been very useful. Every patient that we have in through our ICU is treated as MRO, so multi-resistant organism. We don't have a history on many patients that come to us, and we don't have, in many of our patients, some of them, a short stay. So we use a yellow clean on all our patients. We found that has actually been very helpful in reducing the MRA transmission rates. Medication safety, we rely on our pharmacists very much. Natasha will be talking to us later on in the conference, but basically we have a pharmacy input. This is a pharmacy note on a patient that's had some antibiotic dosing changes from continuous dialysis versus intermittent, and we find these indispensable, and we really value our pharmacists on the round. And we have clearly a MetaVision built-in safety profile for order sets with safety limits. Once again, we're lucky because we have that built into our system. Comprehensive care, this is our first tracheostomy management service, telehealth link up with a patient in rehab. So we had a patient that was in the unit, we were following on the wards, went to rehab. We couldn't see her in rehab, so we tele-linked into her. And this is the first time this has been done. You can see the patient in the background. And this is our tracheostomy management service, which is an outreach service based in ICU and run out of ICU. And this is an example of, I guess, comprehensive care with the patient coming to us rather than us going to the patient, and I think that's been very successful, and that TMS service has been very successful. And thanks again to Sonia and the girls for running that. Pressure ulcer prophylaxis, big buy-in from the nursing staff. We've had Fiona Coyer with us, and we've done programs on interventional programs. She's run a sustained study with us, which has led to weekly nurse presentations, awareness raising, and multidisciplinary rounds, and with that with those interventions we've had a significant drop in our hospital-acquired pressure injury rate right down, and we're still maintaining that. And as I said, there's been excellent nursing and allied health buy into that. And finally, delirium, a big one. We've modified our recent delirium scoring systems on the left there. We haven't got to the stage yet of the ABCDEF bundle that Wes Eli is propagating, but it's an excellent bundle. If you haven't seen it, it's well worth looking at, and maybe you're thinking about adapting into your hospital, which looks at the complete patient care bundle, including spontaneous breathing trials, choice of sedation, delirium assessment, early mobility, which is extremely important, and family engagement and empowerment. So just to summarise, I've tried to give you, I think safety and quality and ensuring safety culture is fostered is everyone's responsibility. How you do your QI is largely up to you, but it does need to be done, and it needs to be done efficaciously. I think we found that a well-designed meeting, a QI meeting, is essential for this. And also benchmarking and quantification of your unit's activity needs to be done, and that's, we have an excellent ACHS clinical indicator program which ANZICs and the college are participating in, and we've just had version 5 released, so well worth participating in and well worth doing if you're not already doing it. And version 2 of the national standards, I think that this is a solid template from which to structure your agenda, and also aligns with ACHS accreditation. Hospitals and ICU should be committed to participation in these standards, and I think that we'll be moving to the new standards next year, which we've already started working on. And I'll leave you with a statement from Battleton and Davidoff. So everyone in healthcare has 2 jobs to do when they come to work: to do their job and to improve it. I thought that was a good little statement. And I'd like to thank you for your attention and enjoy the rest of the